I welcome you all to our e-Gurukul Pathshala PG Clinic. This is a very favorite program in all the PGs. And for today, we have case discussion on neonatology. For case discussion, we have presenter Dr. Surbhi Nair. She is a resident from Department of Pediatrics at BJ Medical College, Ahmedabad. And I also welcome her mentor, Dr. Dhara Gosai. She is an associate professor in the institute and also take care about the NICU and all the NICU graduates. For this today's discussion, we have an eminent expert with us to guide us through the queries and to take us through the journey. Dr. Gaurav Gupta. Sir has done his fellowship in neonatology through IIP and also through the Australia. And he has certified in clinician in performed ultrasound by the Australian Society of Ultrasound Medicine. He is at present working as a consultant neonatologist at Garg Hospital and Childcare Center at Ludhiana. Sir has many awards, honors, and achievement, out of which some few are he has conducted various workshops at various academic firms, setting up a level 3 NICU care at a tier 3 city of India, NNF accredited level 2B neonatal units. He is the faculty at first ROP Conclave of Punjab, and his area of interest is point of care USG and qualitative assessment of general movements. Welcome, sir.
Thank you for the kind introduction.
We also have our guru, Dr. Baldev Prajapati sir with us, and sir takes us from minute things to the major things. So I give all this platform to sir. So platform is all yours.
Good evening, friends. Welcome to this our Pathshala teaching program. And as already Dr. Nehal said, Dr. Silvi is the presenter from BJ Medical College, Ahmedabad. I request Sulbi and her mentor, even Dr. Dara, that request other colleagues to join, other students to join. And
Yes.
even they should keep their video on. Yes. At least Dr. Asmita's name is familiar to me. Probably in the past she has participated.
Yes.
Dr. Sandeep is also there, and even other students should join and even participate actively in the discussion. With these words, I request Dr. Surbhi to start the history part. Dr. Surbhi, please.
Good evening to all the respected faculty members. I'm Dr. Surbhi Nair, first year pediatric resident at BJ Medical College, Ahmedabad. And today my case report is of a case presentation is about the preterm. So my patient is a 3-day-old female child, 34 to 36 weeks, born out of a non-consanguineous marriage to a 25-year-old primary mother on 16th of September 2024 at 1:35 p.m. through emergency lower segment cesarean section in view of oligohydramnios with a birth weight of 1300 grams. Antenatal history. Baby is born to a 25-year-old female with a height of 170 centimeter, weight of 62 kg, and blood group O positive and HB of 11 gram per deciliter. It was a registered pregnancy with an LMP of 15/1/2023 and estimated date of delivery 22nd October 2024. Folic acid supplement was taken in the first trimester and routine ultrasonography was done. Iron and calcium supplements were taken in the second trimester. 2 doses of TT vaccine were also taken in the second trimester. Antenatal USG done at the third trimester showed the presence of fetoplacental insufficiency with the presence of cord around the neck. In view of this, The patient was taken for emergency operation on 16th of September at 1:10 p.m. Emergency lower segment cesarean section was done under betamethasone coverage, which was given 4 hours before the operation. Now we proceed to the natal history. The neonate was delivered at Civil Hospital, Ahmedabad on 16th of September 2024 at 1:35 p.m. Preterm emergency lower segment cesarean section of a 1.3 kg female child, small for gestational age and cried soon after birth. The postnatal history. On initial assessment, the neonate had mild
I think, Dr. Subi, can you just stop sharing for a while?
Yes.
But I think we may not be able to recollect every information as you complete the history. So let us discuss whatever information you have provided. Again, I request all others to keep their video on. Dr. Sandeep, Dr. Heath, Dr. Hitesh, please. I think any comment from the students first or any question for Dr. Surbi. If you want to ask some question or even some clarification from her, more details, anybody? Or some points probably you may not agree with her. Dr. Sandeep, are you there? Please unmute yourself and keep your video on. Another person is very smart, just kept the name D. So you'll have to identify this, who is D and who is C. Dr. Sandeep.
Yes, sir.
First, I will appreciate you that at least you appeared on the screen. I hope that you are also from BJMC?
Yes, sir.
Fine. Any question or any query or any more information, clarification do you need from Dr. Surbi? I hope that you have attended the history part, what she narrated. Okay, I will give you what she started, 3 days female.
Yes.
Any, I will say, your comment on this?
Sir, actually, the age should be mentioned in a hours of life, till 96 hours minimum.
Okay. Then I think you'll have to give the explanation. Why? She will say, well, that what is wrong? What I'm telling 3 days. It's okay. I'm sure that you must be the colleagues. She's going to fight with you after the finishing of the discussion, that you are creating controversies on the screen. What is wrong in the 3 days or hours? So you'll have to give the explanation. Is there certain at least guidelines or ideas that up to what time you should give these hours, then the days, then the months, and what is the idea for giving this, I will say, guideline to us? What they want? I'm sure that suppose 70 hours and 3 days, if say probably may not be that wrong. But why we want so precision?
Actually, till 96 hours, we have to mention the age in hours, sir.
Okay, you know, Dr. Gaurav is there, so I'm secure that something is wrong, he's going to correct. So even I don't have any hesitation. But first you'll have to explain. Dr. Gaurav, I think, can you take this point for the clarification to the students, please?
So it's, I think the only thing is there are certain diseases which tend to manifest with the amount of time, how far we are from the time of birth. So a respiratory distress, which is there at birth, which resolves as the time passes in 4 to 6 hours of hours, is more of a transient tachypnea of newborn, generally, which is something like a wet lung and which is going to resolve. If there's mild distress, as she's going to come along somewhere, and which progresses as the time goes, like worsens at 6 hours, 8 hours, 12 hours significant enough to warrant mechanical ventilation, or worsening of increase in pressure requirement points towards a different etiology, right? Something like a respiratory distress syndrome, which would warrant a surfactant. Similarly, respiratory distress, I'm just giving an example, which comes on day 2, day 3 of life for a preterm neonate, maybe because of a ductus. As the pulmonary artery pressures decrease, there is going to be increased blood flow across the ductus into the pulmonary circulation, which is going to cause a wet lung, and the distress may be because of a patent ductus arteriosus. And then whether it's early onset sepsis or late onset sepsis is clearly differentiated based upon the number of hours at which the problem manifests. I think before 72 hours is generally an early onset sepsis, whereas something which starts beyond 72 hours is a late onset sepsis. Categorization is important because that helps us differentiate the etiology. If it's an early onset sepsis, we are going to go back and look at mother's antenatal history, look at her placental histopathology, or look at swabs to find if there is any problem brewing there.
I think so fantastic examples Dr. Gaurav has given to us. And the medicine we know, even beyond neonatology, that we always are interested what are the onset of disease. And then what was the progress of the disease. And in neonatology, we know that suppose 12 years old boy, and if you're describing here some 1 month or something or a few days, may not make much difference. But what examples Dr. Gaurav has given to us, that when this particular disease or the problem started, the symptom, and then what were the progress, that if you go in the details, that will give us the idea that exactly what I should consider. And for that reason, in any baby, suppose even the good, healthy and hearty, and even after the 40 or 72 hours, suddenly she becomes sinus and collapse. It may happen so. I think that should give us the idea that when it happened. And then we realize, oh, it should be some duct-dependent cardiac lesion because the duct closed during that time, and therefore the baby was fine or not that bad. But as soon as the probably duct got closed by its physiological or routine phenomenon, this very serious problem precipitated. So, it gives exactly the time frame. And the time frame gives you the perfect, probably the suspicion that what different conditions you should consider. And having this idea or understanding, similarly, I will say further, if you go for the jaundice, then we describe the days, that in which particular time the jaundice develops. Suppose some 2 or 3 weeks, different conditions will come to our mind. Early phase differently we are considering. And even for that also, that what are even the first few days or the first week or the second week, that then we discuss in the weeks that when the jaundice develop. Having this, why we go, because that will give me some idea that particular jaundice, when it appears, what is the progress and up to what time it is persistent or even increasing. So that is the idea to give this all the students. And I'm sure that if you have this point in your mind, when you are taking the history, you will go so precisely. And I'm sure that that will guide you. And as even the further information you collect, probably before you go for any investigation, you have the clinical diagnosis in your hand. Just you want for confirmation later on for some investigations or something. And I think that's the beauty of the history, even in the, I will say, era of the advanced technology. That's why I think the days and hours and everything we go. So very good point. Second, I think Dr. Surbi, at present, which preparation we are using for tetanus to the mother during pregnancy? Is it TT is available? Tetanus toxoid?
Yes, sir.
Sorry? I think
Yes.
you should use your mic properly somehow. Your voice is little bit...
Yes, sir.
Is it? Somebody else? Dr. Heath? I think Heath is from GCH. Heath, can you unmute yourself? Dr. Hitesh? Please come on. I think you should participate. I know that you are working in the institution, and in your institution, which particular preparation is available. I think we should know. I'm sure most of you must be knowing. Anyway, anybody refers to her? Dr. Amit? Dr. Jay, I know that gradually as I am growing, I understand that I should keep the patience. It may take some time because students are having hesitation, reluctancy, so many inhibitory, I will say, factors. But I will wait for some time. And I hope that gradually will at least become the interactive. Dr. Asmita, can you unmute yourself? Because I have seen you interacting in the past, so I hope that you may do. Dr. Sandeep? I think why you are afraid of it? Come on. Yes. Anyway, Sandeep has come again. Sandeep, I will appreciate you. And please remember one sentence. Kedas has written, Kedas is a text book on the surgery. We used to read it. He has written, I will say long back the sentence, and I think today also it is so right, that be ready to become the fool for a few minutes. Otherwise, we'll have to remain the fool forever. So why we should remain fool forever? Okay, my interaction, my comment or my answer may not be right. It's all right. Dr. Sandeep, which preparation we are using antenatally for the mothers?
Sir, according to NIS, TD we
No,
are
I
using.
think which one you are using in your BJ Medical College, Civil Hospital?
TD, sir, TD.
TD. Whether the tetanus toxoid is available alone?
Yes, sir, normal TT is also available.
Is it? I think long back this tetanus toxoid had been discontinued, even the government hospitals. The reason is, we wish that now plain tetanus toxoid is not desirable. On the contrary, one more question, I will say, suppose mother is affording. She says that, sir, I want even the better preparation. I heard from my friend. She was also pregnant and her doctor has advised some other preparation. Dr. Asmita, which one you will prescribe? She is ready to spend the money if it requires. If it is not available free, then which one you will prescribe? Pregnant mother.
Sir, we can prescribe TDAP, sir.
Why the TDAP? And well, first I would like to know what is the TDAP?
Sir, it is tetanus, diphtheria toxoid, and the acellular pertussis.
And what are these letters, if you have seen, whether they are the capital or small letters?
So they are small letters.
Why they are small letters? We are using DPT, full, I will say, capital letters. Here, why they have used the small letters?
So the strength in that vaccine is half, which is given in the DPT.
I would say better not to mention the half. I also don't know exactly what is the concentration, but definitely it is less compared to that. Right. And why we are using the TDAP? Why? What is your idea?
Sir, it is for the decreased transmission and for the better immunity of the pertussis and the diphtheria vaccine, because we are delaying that vaccine to 6 weeks in the neonates. We are not giving in the early infancy, that is in the neonatal period, for the protection during the neonatal period through the mother immunization we are covering through TDAP.
But I have heard in the past, even when we were students,
yes,
that mother is having these antibodies against diphtheria and pertussis, and they are transmitting to the baby. But what is the need of these pertussis and diphtheria components? Already mother has it.
So the immunity gets wane off within the 6 to 12 years after the immunization.
Very good. I will say rather than give the time frame, it's certainly that as the time passes, even the supposed mother is immunized in her childhood, even adolescent age group, gradually there is waning of these antibodies. and particularly the pertussis component. Why we are afraid of the pertussis component? I think just naming SK, can you rename yourself? Because I don't understand by the short form. I understand in the era of the computer, we are using the short forms everywhere. The student or the candidate on the screen so that I can talk to you. Asmita, why we are afraid of these pertussis?
Sorry, sir.
Why we are afraid of the pertussis component? Why we want to cover it? Why want to give it? What was my idea? Let me make the point clear. You know that neonates can develop the pertussis. And if you know the pertussis having the more morbidity and mortality, more complications in younger babies, particularly the neonates. And you know the adults are transmitting the pertussis. Adults may not have the classical features of the pertussis. That's very bad cough. On the contrary, the physicians now they are discussing that any adult who complains of very bad cough, that means some constant bouts of cough, sometimes when following that he has some sputum, they may not say vomiting, but this is sputum with the pertussis, and that is the point that they are transmitting. And therefore, what we want, that mother, if given the Tdap, that antibody will transmit to the baby, and baby will get the protection till you start this active immunization at 6 weeks. Is there any other, I will say, circumstances or situation you know where we are using the Tdap for this type of the prevention of pertussis in the younger babies? Yes, Dr. Shivangi. Very good that you corrected your son, your name. Come on.
Sir, it is also given to their grandparents to prevent transmission to the babies.
Very good. I think you must have heard some of your relatives, if they are US particularly, and somebody has got this, I will say, young baby, and when the grandparents are visiting, that is mandatory that they should go with the Tdap, because that pertussis can be prevented even to this new baby. So I think this is the point which I just wanted, that we should know, and in the exam, somebody is going to ask you all these questions. So you should be aware of the Tdap and everything. Second thing, what she mentioned, emergency LSCS. Dr. Surbi, can you explain that what were the emergency LSCS? What were the indication?
There was uteroplacental insufficiency, which was diagnosed in the third trimester, that in the USG done at 34 weeks, where there was presence of cord around the neck. And so that was an indication for the emergency LSCS.
Okay. I think another thing which you have mentioned, that betamethasone was given. To whom? The mother? And what was the indication of betamethasone?
For the fetal lung majority.
Okay, how it works? Let us try to learn. Shivangi, can you make some comment that what is the role of betamethasone to the antenatally to the mother? What is our, I will say, idea, then what preparation, what doses? I'm sure this question is going to come in your either the Viva or somewhere in the case discussion.
So may I raise a question?
Sir, yes, certainly, sir. Please. I was waiting that once these things are over, we'll take your expert comments. Please continue.
Sorry to interrupt, sir. Just as an addition, as a textbook definition, emergency LSCS is when time from decision to incision should be 30 minutes.
Yeah.
So that is one thing which we need to learn, because that's some examiner may ask you, how do you define emergency LSCS?
Absolutely.
Emergency LSCS is decision to incision is 30 minutes. Please carry on. Thank you.
So I think this point is very important, because that indicate that promptness we should have. That means once we decide emergency CS, That means once you decide on the even incision, that duration, that means in the 30 minutes you should be able to manage so that problems or complications to the baby can be minimized or can be avoided. And I think this is a very good point which all of us should keep in mind. Anyway, Shivangi, come on. Take some points, beta-methadone. Then with the more I will recent concepts will go to Dr. Gaurav. But first the students.
Sir, antenatal steroids are indicated in mothers where the delivery is planned before 34 weeks of gestation, and it is to prevent respiratory distress syndrome, intraventricular hemorrhage, and necrotizing enterocolitis. So for betamethasone, the dose is 12 mg, 12 hourly for 2 doses. And like at least the last dose should be completed at least 24 hours before delivery for maximum effective occur.
Yeah, but Shivangi, here there was no time. So is it okay to give the
Yes, sir.
beta-methadone?
Rescue dose can be given even if proper duration is not possible. Even one dose may help, but it is recommended that the last dose should be given 24 hours before.
Okay, suppose my nursing staff says that the beta-methadone is not available. Will it do with the dexamethasone?
Yes, sir. Dexamethasone can also be given.
What is the schedule or this dose?
For that, it is, sir, 6 milligrams for 4 doses.
Okay. Why the people say desirable beta-methadone? I'm not sure whether it stands right today. We'll ask Dr. Gaurav. But in the past, we were taught that yes, beta-methadone better than dexamethasone, this preparation. I think let me go to Dr. Gaurav for this clarification. Sir, can you take it in details that how this steroids works? And I'm sure this is very vital point for our general pediatrician like me. Please.
No, sir. Thank you. So antenatal steroids, as mentioned, are very important. The typical guidelines which American College of Obstetrics and Gynecology and Royal College statement has come is 24 to 34 weeks of gestation. The lower limit is 24 weeks, upper limit is 34 weeks of gestation. If we feel the delivery is imminent in a week and there has been no steroid administered in the last 1 week, we need to give one course of steroids. If we are giving betamethasone, it is 2 doses, 12 milligram each, 24 hours apart. Ideally, the delivery should be 24 hours after the last dose. However, the betamethasone preparation which is available in India is not the preparation which is desired, because that is not the preparation which has been or which was tested for overseas. So what we have with us is dexamethasone. Dexamethasone is 4 doses, 6 milligram per dose, 12 hours apart, total for 4 doses. So in nutshell, steroids, antenatal steroids is something like a bullet. You use it only when the delivery is imminent. You know it is going to happen. So you need to be very sure. You need to do your fibronectin levels and make sure your cervical length is short enough or the delivery is imminent enough. So use it if it is required. Avoid unnecessary usage, and if you have to repeat it, you can repeat. Give one more repeat, preferably before 30. It should not be given after 34 weeks. Before 34 weeks, only if no steroid has been given in the last 1 week and you think the delivery is imminent in another week.
Thank you very much. I think you made the point clear. At the same time, Dr. Gaurav, people say that what complications can be prevented in the preterm? What I think Dr. Shivangi enumerated out of all these complications, is it so that all are prevented, or what are the chances of developing this even in spite of the steroids?
Whatever we have found that they have beneficial effects for the respiratory system. It helps in the maturation of the cells which are involved in surfactant production, promotes the release of surfactant from already which is formed, helps in membrane stabilization, thereby decreasing the incidence of intraventricular hemorrhage and necrotizing enterocolitis. It does bring down the incidence and associated morbidity with IVH, RDS, and NEC. But yes, there is still a possibility of this happening, but the severity and the frequency is definitely going to be lesser with these steroids. But at the same point, unnecessary steroids need to be avoided both because it has unwanted effects in the mother and the baby. It is going to put her sugars all up and down if she has gestational hypertension, especially during the last trimester. And there have always been issues with steroids in neurodevelopment outcome for the baby at 1.5 or during subsequent development. So steroid is a gun which we need to use only when it is required.
Thank you, Anand. I think he made the point so distinctly clear that we should not use the steroid blanket covering. We should know its hazards also. And very specific time frame, even indications he has given, even what is the exactly role and its even the limitations, even the hazards. That also we should be aware of it, and accordingly we should use it. I thought that this is very important point for even our practice as well as for even exam. And Dr. Gaurav has make it very clear. I think having this information, Dr. Gaurav, anything or should we go for the further history part?
I think so.
Okay.
I think she's nearly done it.
Okay,
Yeah.
so let her finish, then again we'll be back for the discussion.
Yeah.
Dr. Sulbi, you can take it further and complete the history part.
Postnatal history. On initial assessment, the neonate had mild subcostal and lower sternal retractions with nasal flaring with a Silverman-Anderson score of 6/10. Neonate was shifted to NICU in view of respiratory distress on O2 bronchs with resident doctor and was later put on nasal CPAP with FiO2 of 21% and 4 liters of oxygen. On receiving, the temperature was normal, O2 89, CRT was less than 3 and RBS 101 mg per DL. Ballard scoring showed the presence of creases on the anterior two-thirds of the sole, raised 3 to 4 mm alveolar bud, well-developed labia majora and minora, formed and firm ear cartilage with instant recoil, testes down with good rugae, absent scarf sign, and other features which gave a score of 27, suggesting of a 34 to 36 weeker neonate.
Sulbi, I think before you go further, would you like to correct this last point? Regarding after this ear cartilage, what did you mention?
With instant recoil, testes down with a good rugae and absent scarf sign.
At the same time, you have mentioned that labia majora were also well covered.
Sorry, sir?
I think before that you have mentioned that well-developed labia majora.
Sorry, sir.
So it's a female child, right?
Yes, sir.
I know that sometimes what happens in the exam routinely or in this type of the presentation, if you use the old presentation, sometimes you may miss to delete it. But the point is when we are talking, I think you should have all these points in your mind. Okay, go ahead.
Suitable chest x-rays were also done, which showed no abnormal finding. RT feed was started at 80 ml per kg per day. Feed was tolerated and the feed was increased on a daily basis. KMC was explained to the relatives and the same was ensured. Respiratory distress decreased and neonate was weaned off to O2 bronchs at the 24 hours of life. Neonate was then shifted to room air with the settling of respiratory distress. RT feeds were tolerated. Non-nutritive sucking was also initiated on the 4th day of life. Family history.
I think, can you just stop sharing before that, whatever you have described? I request Dr. Gaurav to take it further for the discussion. I think postnatally, whatever the incident happened.
Surbi, I have a couple of quick questions for you. You mentioned FiO2 of 21% and CPAP of 4 liter. So I think what would be more important on when you're mentioning CPAP pressures?
So you also need to mention the P, positive and expiratory pressure.
And what is the influence of low on a CPAP? Would 4 liter of CPAP pressure work?
sir, when there is mild respiratory distress?
I think sorry to interrupt. The role of low is just it should be enough for the bubbles to happen. If you're using a bubble CPAP system, generally what the company says is minimum or the lower limit is 5 liters. Upper limit you can go as high as 8 liters. The only thing we go low is because we are pushing air not only into the lungs but also into the tummy, which is further going to cause abdominal distension, which is going to push the diaphragm and going to decrease your intrathoracic volume, which is further going to compromise your ventilation. So you should not be really mentioning CPAP of 4, mention it as 5. And more importantly, you should be telling a pressure, a PEEP value, what you are delivering. Right? Now, the second most important thing is what should be your target saturations for such preterm babies?
So, SpO2 values are between 90 to 95, sir.
I would just like to correct it, make it 91 to 95. The NEOPROM study published in 2017 has been very critical, has been very clear about it. Should be between 91 to 95%. And you can set your alarm settings 2 or 3 lower and on the either side. Because too low is going to be at the cost of decreased oxygen-induced various tissue damage, you're going to increase morbidity and mortality. Whereas if you're giving high oxygen, it's a medicine, it should be used with caution. So high oxygen is going to damage your lungs, your eyes, your brain, and is going to cause injury, free radical injury to your gut. So looking at 89%, there should have been some corrective measures because 89% is not normal. So that is something which needs to be looked into. Now, there's one more important thing which I need to bring up. We started off, I think you in your history slide, you said gestational age between 34 to 36 weeks. Now, if we have clear-cut last menstrual period and expected date of delivery, as per history, the gestational age of the child in question is 34 weeks plus 6 days. So we should not be giving a blanket term. So 34 to 36 weeks is more on your Bellard scoring. So if you are giving as a history, you should be very clear about your gestational age. Right? And one last comment which I have to make is, do you know how do we like differentiate prematurity? Do you know the sub-classifications of preterm gestation? Anybody? I think the question is open for everybody.
Yeah, other students should also respond. Come on, Shivangi, Dr. Amit, Sandeep, Disha. I think so many names I'm able to see. Come on. Shivangi, what will be your response to Sir's question?
Sir, it is early preterm and late preterm. So, sir, 30, early preterm and late preterm. So, late preterm is after 34 weeks, 1 day.
No, this is not correct. Anybody else would like to have a go?
So, less than 28 weeker is extreme preterm. 28 to 32 weeker is early preterm. 32 to 34 weeker is moderate preterm. 34 to 36 weeker is 34 to 37 weeker is late preterm.
Yes. So whatever. Sorry, I don't know your name. Sorry.
Sandeep.
Sandeep. Whatever Sandeep has said is right. This was published in JAMA in 2013. So anything less than 37 weeks is preterm. Now they have been further classified as extreme preterm, very preterm, moderate preterm, and late preterm. So extreme preterm is anything which is less than 28 weeks. So very preterm is 28.0/7 to 31.6/7. So 31 weeks 6/7 is very preterm. A moderate preterm is 32 weeks 0 days to 33 weeks 6 days. Late preterm is 34 weeks to 36 weeks 6 days. Does it make sense? 6/7 0 by 7. Yes. Now, further, the lady who was speaking just before Sandeep, she said,
Shivangi.
she said early preterm, late preterm, and one more word, moderate preterm, I think she was using. So there is no terminology as which you spelled out. The word, whatever Sandeep has spelled is correct. Now, even the term has further been classified into 3 categories. There is early term, full term, and late term. So early term is 37 weeks, 0 days to 38 weeks, 6 days, right? Full term is 39 weeks to 40 weeks and 6 days.
6 days.
Yes. So late term is 41 weeks to 41 weeks, 6 days. Anything more than 42 weeks is post term. Because the etiologies are early term is not same as full term. Whenever you're going for planning for an elective cesarean section, it should not be done in term the early term gestation, because we have found that the lung is not mature enough. There have been issues of respiratory distress syndrome happening in early term babies. So elective, a lot of these, I'm sure it would be happening in Gujarat too, or wherever you're from, regarding these Muhurat babies. They want कि पंडित जी ने टाइम निकाला है, 37 वीक्स हो गए हैं, डिलीवरी करना है. So that is a big no. So 37 weeks, 0 days to 38 weeks, 6 days is early term. They have a different physiology. They behave differently from a full term, which is 39 weeks to 40 weeks plus 6 days. A late term is 41 weeks, 0 days to 41 weeks, 6 days. And we all know more than 42 weeks is post term.
Absolutely. I think I would like to remind to the students that why we are discussing so much and going even so much these, I will say, groups and subgroups. At least I remember then the older days we used to say pre-term, term, and post-term. That's all the 3. That why we have gone this, even the subgroups, or what is the idea? Why we have conceptualized this point? Shivangi, any idea? What I mean to say in other way, that what is the importance of dividing these babies so precisely, so category, that particular, if we want very precise category, not just preterm. Why we want so much? What is their idea? It is just for the sake of exam to ask these questions? Or is there any other idea? What is and I'm sure that if you understand the importance, you will try to remember it. What is the importance of all these categories? Even what Dr. Gaurav said, even if the term also is not simple term. So what is the idea? Dr. Surbhi? Why we want, I will say, so precision? Even what Dr. Gaurav said, weeks and days, even 6 days. And then one day we are changing the category. Partly Dr. Gaurav tried to answer even when he was talking. I hope that you must have noted. Anybody, any student? Hey, Aditi, did you note anything? I hope that you were listening to Dr. Gaurav when he was talking very, I will say, precisely. The point or message which I want to convey, I'm sure Dr. Gaurav will agree with me, that later on we got that simply what we consider preterm, and whatever the decision we take for this delivery of the baby, either the CS or emergency or normal, or what problems of the baby we are expecting, they are not the same for all these weeks. They differ at the different category. Even what we used to say borderline preterm initially, that borderline preterm we were considering that, oh, it's a term baby. Later on, we realized that several babies from this group develop the respiratory hyaline membrane disease. What I consider term baby, but significant number of babies from this group, what we say borderline, And then we understood the importance that better to go for this category, exact category, precise category, where probably your decision for whether the baby should be taken out or can you wait to keep the baby in utero, or what is the reality of the possible this lung maturity, and what are the expected problems after the birth of the baby, which probably mentally we should be prepared to tackle it. I'm sure that having this idea, we have gone for it. Dr. Garo, is it right or something else, please?
Perfect, sir. That is what the point is.
Therefore, I think
Because physiology is changing.
Yeah, physiology changing, absolutely. And you know, in the, not I will say as a whole neonatology, but more so in the neonatology, I'm sure what Dr. Gaurav, like neonatologists, said that you should know the best of the physiology. As such, in any disease process, as a clinician, what we are trying to establish this physiology, its normal functioning. And in the due course of time, the disease may be over and probably we will be in the good condition. That is the main, I will say, concept. And therefore here, even in the weeks or days also, the physiology maturity is changing. And therefore the manifestation of the disease and even our protocol for the management is also getting changed. Having this concept, we go more precision. Accordingly, we can plan for this even our action. I think this is the concept which we should know, and then we should remember, and accordingly we should go. I'm sure that this is a very important point what Dr. Gaurav has made. Dr. Gaurav, should we go further?
Yes, sir. Thank you, sir.
Yeah. So, Dr. Surbi, you can take it further. Why I'm interrupting you? I'm sure that you can complete the history, but then we'll not be able to remember all these points.
Yes. Family history. Father of the neonate was 27 years old and mother 25 years old. Both of them studied till the 6th standard, and father is a laborer and mother a housewife. There is no history of hypertension, diabetes mellitus, and thyroid disorder in the family. There is no history of abortion or stillbirth. General examination. There was no pallor, jaundice, cyanosis, or edema. Moro's reflex on examination
I
was
think again, Dr. Saurabi, sorry to interrupt you. Can you just stop sharing for a while? I think then we'll go for examination. And what was the issue with the baby which you described? You narrated with the respiratory problem. What is your interpretation? From the history we should go. Then I'm sure that on examination probably our thoughts may get changed. Any student, that what Dr. Surbi described in details regarding the mother status antenatally, then the mode of delivery, then the postnatally, what the baby developed, the, I would say, incidents, how it was tackled, and how we are interpreting it. That what is the likely issue with the baby? Surbi, what is your interpretation? I'm sure you must be knowing.
The mother's nutrition status.
No, I think regarding the baby's respiratory issue. In other way, if I directly ask you what the respiratory problem or distress was due to the hyaline membrane, was it due to this really transient tachypnea of newborn? Was it due to some cardiac cause? Was it even due to some neurological complication? Or was it just like congenital diaphragmatic hernia or something? What is your interpretation that what is the likely issue with the baby? What happened the postnatally?
Was because of the prematurity.
Okay, but prematurity, what problem you are in? Was it pneumonia? Even that can also happen in the preterm baby.
So hyaline membrane disease.
Okay, so Surbi is interpreting hyaline membrane disease. Anybody else? From the history. You know, always we are talking, I will say in any specialty, more so even the neonatology also, that from the history try to derive that whatever the information, data we have gathered, from that analysis, how we are interpreting, what is our inference, or what is our hypothesis? That this respiratory problem is due to what? Is it due to the respiratory system problem, then what problem? Or really some other system made the child breathless? Of course, you are on examination, sometimes our thoughts may get totally changed. And occasionally it may happen so that on investigation, maybe the third condition, quite possible. But at least we should go for our hypothesis, our interpretation. So here Dr. Surbi says that was due to the prematurity and likely hyaline memory disease. That is her interpretation. Sandeep, what do you believe? What is your idea? Or even, can you go for any next possibility? Suppose if you keep one is the hyaline memory disease. Any other next possibility?
So it could be due to transient tachypnea of newborn, as the mother has undergone cesarean section.
Okay.
As the mother is having oligohydramnios, there can be lung hypoplasia.
Okay. So this is second possibility. Shivanji, what is the third possibility from your side?
Sir, it could also be due to early onset sepsis.
Okay, very good. Then fourth one, I think somebody else, Dr. Asmita. Anyway, suppose among all these possibilities, now what will be the first, second, and third? We'll have to put the chronology. Having this information, already we have discussed a lot. Sandeep, what will be your chronology? Which one first, which will be second and third?
First could be, sir, due to transient tachypnea of newborn.
First one.
Yes, sir.
Okay, second?
Second could be hyaline membrane disease, or third could be early onset sepsis.
Okay. Can you justify your stand? You know, in the medicine, whatever we speak, we should be able to explain that why you are. Suppose on which ground you are considering transient tachypnea as the first possibility. What is your explanation?
Because
if I ask a very direct, precise question, what is the usual time of the becoming the child breathless in the transient tachypnea of newborn? At the time of birth, after a few hours, or at what time? And then what is the course? Whether it remains the same, whether it deteriorates or gets improved. What happens? And what happened in our patient? Think in this way. Let us go to Surbi. Surbi, child became the breathless or respiratory distress after how many hours of birth?
Delivery only, the labor room, the child was having distress.
At the time of birth only?
Yes, sir, within an hour.
So I think I will take it some other way. It was the birth asphyxia. I think that is the most common cause. So Surbi is helping me. That somehow all of us are missing. It was the case of hypoxic ischemia. So now that also we'll have to explain. If say yes, then what is the reason? If no, Asmita, can you take this point? Why not birth asphyxia? On the country, you know, even it is said that it is the most common cause in our country. So why not the most common cause? Then I think I am right. It's a birth asphyxia.
So for birth asphyxia, we have to comment upon the APGAR score.
Okay. Probably Surbi must have missed it. She has not mentioned, but suppose it was affected. Maybe. What is my idea? That in the exam or somewhere, people are going to ask you for an explanation. That means classically, suppose the baby has hypoxic ischemia, how the baby presents and what is the chronology? What is it immediate at the time of birth? What happens to the baby? And ultimately, what would be the course from which you can say that this is hypoxic ischemia? As I think already what Dr. Sandeep was explaining, transient tachypnea of newborn, you know, usually that starts in the few hours of birth. baby remains even breathless, but baby will be acting alert and even may require some oxygen support. But as the time passes, even this it declines in distress, and in next day or so, baby is fine. That is the most common story. And we say, oh, it's a transient tachypnea newborn. Highland memory disease, what happens, all of us know. It starts after a few hours, become the breathless, then it becomes the progressive. Severity increases, may require the even one by one the supports, right? May require the oxygen, may not be sufficient. You have to go for CPAP or may not be, and sometimes ventilator support. Even you have to go for surfactant therapy, and then probably may show the improvement or so. And that type of the usually common course. Of course, it depends upon the severity of disease. Every time it may not be the same course. And even at the same time, early sepsis, we know that even if at all, premature rupture of membrane, or at least some source will have to get it. Or mother was having some history. And then the manifestations and further course of it. So what was my idea to take you for this discussion? That from the history, give the thought that what was the chronology of these symptoms or the problems. What are the onset, what time, already we discussed. That is very important. And then how it was progressing. And even what type of the treatment is required for this management. That will provide a lot many information, and accordingly we can consider the possibility, and most of the times we will be right. I think that was my idea. Dr. Gaurav, anything before we go further, please, from your side?
Yes, sir. Very rightly said. The only thing in what happens in neonatology is what sir has said is very, very good for exam purposes. Now, as far as practically managing is concerned, generally we need to put a wider net rather than being limited to one diagnosis. Because and the more we think of multiple diagnoses, and then we ultimately decrease our diagnosis or pinpoint to one based upon what our other findings are. Like sir said, if I was there, I would first and foremost put my foot down on thinking it as Hale and membrane disease, which is more of a pathological diagnosis. I would say respiratory distress syndrome. Number two, I could put up as asphyxia, lung damage. Third is pulmonary hypoplasia. Fourth, yes, definitely, I would consider that there is some form of early onset sepsis which we are never aware of. I would definitely be drawing my cultures, think of starting empiric antibiotics if I feel the history is there, and then stopping it if everything comes fine. And foremost, there could be some amount of persistent pulmonary hypertension of newborn. A child, a preterm 34 weeks, who's having decreased blood supply, who is small for gestational age, whom we are thinking of asphyxia, or there has been some compromise in your intrauterine, I think I should just keep some clinical suspicion of persistent pulmonary hypertension of newborn.
I think,
We go along the course,
yeah.
I think
Please, Dr. Gaurav, continue.
we would be able to get the diagnosis. Sorry, sir. As we go along, we would probably be able to come at the diagnosis. Once we look at the progression, if it is progressing, worsening, and if the X-ray is showing features suggestive of respiratory distress syndrome, I know I'm dealing with respiratory distress and I need to give surfactant. Whether I give non-invasive or invasive is how competent my unit is and how good we are able to manage. If it is my second diagnosis is asphyxiated lung injury. Now, for that, if there are no other clinical features of asphyxia, no neurological features, no autonomic nervous system manifestation, then the child is growing well. I think I would push my diagnosis further down. Now, number three is pulmonary hypoplasia. Yes, there is a possibility because we know amniotic fluid is very much required for the development of the lung. So even if it is pulmonary hypoplasia, that I would get an idea on how good or bad my lung expansion is and how good or bad my lung is to ventilate. So even if it is, it will still go, the management would be respiratory support plus minus surfactant. If there is a pre and a post ductal saturation difference greater than 10%, and the saturations are lapile, that would point towards more of a clinical diagnosis of persistent pulmonary hypertension of newborn. So this is because sometimes in neonatology, we start off with one pathology and slowly, if not properly managed, we get a mix of pathologies and we need to deal with them individually.
I think Dr. Gaurav has talked very appropriately. Let me take a few minutes for this concept. And I think it is very important for the students. The teacher like me, many a times I'm talking in the rounds that why unnecessary you start the multiple drugs. First go for the details of examination, after the details of history taking, derive some clinical diagnosis, and even plan further investigations, accordingly go for the medicines. But this we should be very clear in the concepts that here this is for the stable patient. When the patient is giving me the time, I will utilize that time for I would say, exercise to come some conclusion. But every patient, it is not applicable. What Dr. Gaurav said, I agree with him 100%, that the student should know. That, and more so, I think, in the neonatology. That they present, whatever the condition, their symptoms and signs are fixed. Decreased activity, not taking feeds, perfusion decrease, and some deterioration. That can be with any condition. So I think symptoms and signs are not guiding me very appropriate or precisely, which happens in older children or even the adolescent or adults, which is not, I would say, so clarity in the neonatology from the symptoms and signs point of view. And second point, if I wait even for, suppose I decided the hyaline membrane disease and I don't start the antibiotic or something, I think that may, because neonates, they are deteriorating very fast for whatever the condition. They don't give us the time. And here again, I don't have the time for going all this. And therefore, what Dr. Gaurav said, one sentence, it's very good, that initially keep the various possibilities, start even your action, go further workup, and suppose once you come to know that X-ray is normal or culture is negative, I think sepsis is not there, then you can safely stop the antibiotics. But initially, if I don't start, I think it's not the right decision. Here I will have to. And what sir said even later on, suppose X-ray or something, and you get the very peculiarity of hyaline membrane disease, we cannot wait, go for the surfactant therapy. The reason is, what was my idea to discuss this point, that in this type of situation, we don't get the time for making all the decision. And if we wait, probably there will be complications or even the mortality. But as we probably follow the patient, the point we should keep in mind of the de-escalation. I started, but once I'm clear, go for the de-escalation. I think that's very, very important point. And I think Dr. Gaurav made the point very fantastically, very, very important in our daily management. But okay, Dr. Surbi, you can take it further. I'm sure that we have taken more than 1 hour in the history part only. And I'm sure it is justified. If you take more part in the history, I think the examination points are clear.
So in general examination, there was no pallor, jaundice, cyanosis, or edema. Morose reflex was incomplete. Anthropometry weight was 1300 gram, length 47 centimeter, and head circumference of 32 centimeter. On head-to-toe examination, the head was normal. Fontanelles, both anterior and posterior, were leveled. Neck and chest were normal. Umbilical cord was dry, no bleeding, and there was no meconium staining. Genitalia, back and spine were normal. Extremities were also warm. On systemic examination done on the 4th day, neonate was maintaining saturation 98% on room air. RR was about 38 per minute, regular without any signs of distress. On auscultation, bilateral air entry was equal and clear. Heart rate was about 140, pulse was well palpable, and there were no signs of any murmur. The neonate was alert with good activity and sensorium. Abdomen was normal in shape with bowel sounds heard.
Okay. Can you stop sharing for a while? I think first always the chance to students. I think Surbi, you have got the good friends. They are not creating trouble for you. Ideally, I think other students should have so many questions and queries. And Surabhi should find the difficulty in answering or responding to all queries. So I think I'm not sure, or probably they're protecting you. Shivangi, come on, Sandeep. Even Nistha, I think Nistha also in the past I have seen that she's interacting very nicely. Shivangi, first, any comment from your side? Whatever she narrated the examination, where probably you may not be happy, or you want some clarification, or you have some comment, you can make whatever the point is with you.
So one point was that she mentioned that Moro's reflex was incomplete.
Very good.
But like during there were no any history of any resuscitative events or any delayed ride or any issues during the delivery. So that doesn't corroborate.
So Surabhi, what is your explanation? What Dr. Shivangi is asking you? That she's not happy with the incomplete Moro. What is your explanation? That means she's not expecting. But still you have got an examination. So what is your explanation? I think before that, let me make the point clear for the sake of other students also. Shivangi, what do you mean by the incomplete Moro?
So in incomplete Moros, the last part of the last component of the reflex that is.
Can you? I will say take few minutes and explain that what is the normal Moro reflex, because you know the Moro reflex is very important in the newborn, and that probably every person who is looking after the newborn or baby should know. And if you are really vigilantly doing it, observing, it will help us a lot. So Shivangi, can you take it? Usually it develops at what? I will say age. What are the components? And even at what time it disappears? And what is the complete, incomplete, and some people say asymmetrical also. And occasionally when I heard reverse Moro also. So what are these all terminologies? Can you explain? I'm sure that somebody may ask you. Now you can take it, Shivangi, your own time.
So, sir, the components of Moro's reflex are first, like when we put the support the baby's trunk and the head on our forearm, and at from 45-degree angle, we let the baby fall. And then the first component is abduction and extension of a shoulder joint and the opening of hands. And then the second component is adduction and flexion, and it may or may not be followed by crying. So, sir, these are the components of Moro's reflex. Incomplete Moro's is when the last component of adduction and flexion and closing of wrist is not present. And asymmetrical Moros could be found in if there is any birth injury like shoulder dystocia or any nerve injury due to which one side of the arm is injured. And it usually it goes off by 4 to 5 months. By 5 months, it is after that it is not at all present.
Okay. And what is the reverse Moro? Have you heard? No idea? Anyway, I think let us try to learn from Dr. Gaurav, because this is something important reflex. Either in the theory somebody may ask, or even I'm sure newborn short case is always there. So they are going to ask us. Please, Dr. Gaurav, can you take for the sake of all of us?
Sir, I'm not sure about reverse Moro's reflex. I'll have to check, sir. I'm not sure about reverse Moro.
Right. I think rest of the parts what she described.
Yes, they are pretty much right. So what she's said is it's going to be initially an abduction component with extension, then an adduction with flexion, followed by a crying component. Now, as we know that the tone, as we also look in Ballard scoring, that the tone tends to progress from distal to proximal ends and goes from the lower extremity to the upper extremity. So the flexion component journey tends to come a little later than the extensor component. So as we mature after 34, so incomplete Moro's reflex at 34 weeks is absolutely fine. As the child matures further, comes near term gestation or term gestation, we can get a complete Moro's reflex. And it generally disappears by 3 to 4 months of corrected gestational age or postnatal age. And incomplete or asymmetrical is very much a part of birth injury. That itself gives us an indication whether there is any clavicular injury or whether there is any humerus injury or whether any brachial plexus injury, which is very common in part of newborn trauma, can lead to asymmetric Moro's reflex.
Yeah. I think open question to the students. Many times somebody may ask support like Shivangi, Surbi, they are responding very nicely. Then who was Moro? Any idea who was this? Whether it's a name of person or town or how the name is derived? Anybody having idea? Shivangi, do you know who was Moro? No idea? Surbi? I think other students, where are they? I think we should know regarding these people also, who contributed a lot in the science. I think reverse Moro, you can check it, probably mentioned in Dr. Merban's book, Care of Newborn. And even at some other place also I did, probably long back. Reverse Moro is usually exaggerated Moro response. All the components are exaggerated with some facial expression. And that is very specifically with the kernicterus. You may get it, this reverse Moro. And Moro was the person, actually, very few pediatricians are there to contribute in the science. Even in the pediatrics also, either some scientist or pathologist or somebody. But this Moro was the pediatrician. It was Australian pediatrician who got it. And I think then somebody will ask Shivangi, who was Abgar? We are talking so much daily, the Abgar score. Any idea? Just remember, again, the Abgar was she. And she was an anesthesiologist. Yes. She was an anesthesiologist. And therefore, today, even some anesthetists say that we were the people to start or even explain this resuscitation in the newborn. And I think they may not be totally wrong. I know that sometimes when there is some discussion even for the newborn resuscitation or something, some anesthesiologists say that we were the first people to start this art of resuscitation. And I think they are not wrong. These are I think, some general knowledge questions somebody may ask you, but I'm sure that very important, we should know. I think one more common question. She said the umbilical cord. Shivangi, how will you take the care of umbilical cord? Or even before that, I will ask you, you are there attending this labor call. Now the baby is out. Regarding this cord, what you will points suggest to the obstetrician? And even in your presence, what points you will mark? Note it. What are the points to be noted? Number one, I think if I ask the direct question so that you can have the more clarity. After the baby is out, after how much time will you apply the clamp?
Usually, sir, it's ideally it should be done after 1 to 3 minutes.
Okay.
That is delayed cord clamping.
What is the idea?
So that the baby receives more blood and like the support from the mother is continued for a little more time. If to better help the baby adapt to the transition.
Anyway, I think Dr. Garu will contribute later on. Let us make the point clear. Then second point, what should be the length of the umbilical cord? How much we should keep it? Some people will cut even clamp from this base or just even beyond base. Some will keep it very long. So is there any guideline that roughly what should be the length of the umbilical cord? And what is the idea even for that guideline? Or just somebody has said? Just Sandeep has now appeared. So Sandeep, what is your response? Meanwhile, Shivangi can take some deep breathing. Come on.
The length should be approximately 2 to 3 centimeters. The idea is to the stump should not reach the genitalia of the baby.
Suppose somebody is cutting from the base only. What is wrong? Initially, many times when I'm discussing such points, like Dr. Gaurav, the expert person, may feel boring even that, or even he may feel.
Sir.
But
it's no, sir. It's such a learning experience, sir. Such a learning experience.
But I think if you are more clear regarding
Very
the
important,
basics,
sir.
then I'm sure, because routinely, daily, we'll have to take care of all these points. Then we'll have to go for advanced some problems or complications. First, we should be clear. And I'm sure that this is very, very important, that why even they have given some idea. And Sandeep, that is not, rather than the 2 centimeter or so, it is 2 inch, 2.5 centimeter inch, 1 inch. That means they have given the guideline 4 to 5 centimeter. Why the 4 to 5 centimeter? That's why I said, suppose somebody is cutting at 1 centimeter. What is wrong? Any complication or problem can develop. Let me give you some hints or ideas. It is known that if you cut too short, there is possibility of developing some problem or complication. Which are the complications? Are there any contents in that umbilical cord possible? I think if you know the embryology, what are the structures in the umbilicals? Then they regress and they go inside the baby. But sometimes they may remain or may take some time, or maybe as a remnant. And if we cut, what complications can develop? What are the contents? First, I think, and that's why, we should know the contents. Therefore, they were first explaining the embryology, then anatomy, then physiology, because they were very clear that if you are knowing, it is going to be useful. There can be some yolk sac, urachus. Have you heard the name? The structures are possible, and if you cut it, we may create the urinary fistula or fecal fistula. That's why the 2.5 centimeter and too long, what Sandeep said, yes, to prevent this sepsis or infection or soiling of the umbilical cord. Total care. So I think these are the small points, but certainly we should take care. We should know. And one more point, what Surabhi said, no murmur. So Shivangi, no murmur means no cardiac problem. I'm sure. Is it right? My resident said that there was no murmur and therefore no cardiac problem.
There are certain congenital heart diseases which could present without murmur.
We are talking in newborn, not even in general older children. So what are the conditions? Suppose if you made the statement that some cardiac conditions can present without the murmur. Okay, can you enumerate few common?
Sir, there could be transposition of great arteries.
Okay.
Then
that means some conditions where murmur is not there. Cardiac problem is there, but they don't manifest with the murmur. Maybe some other manifestations. Many times what we decide that no cyanosis, no murmur, so no cardiac problem, no cardiac anomaly. And therefore I'm asking, are there any condition which may manifest later on with the cyanosis even?
ventricular.
Or even at the time of examination, but no murmur, but still some possibility of cardiac condition. Which are they? Sandeep, any idea?
Cough with pulmonary atresia.
Okay. Shivangi, if I give the small response to your question, I will say to your answer. If pulmonary atresia, what happens? Think for a while. Think for a while. Any condition with the pulmonary atresia, what happens? I think there is no flow to the lungs. Am I right? If there is no flows to the lungs, there is no oxygenation of the blood. If no oxygenation, what will the manifestation? Cyanosis. And if no flow to the lungs, there should be some shunt which will divert the blood in the lungs. Some mechanism should be there for existence or survival. That's the principle, right? So pulmonary atresia usually will not be like that. I think one more point Surupi had missed on examination. Surupi, did you examine for the femoral pulsations? I'm not sure whether did you mention? Dr. Surupi?
Yes, sir, I didn't mention.
You have not mentioned. Okay. Sandeep, what is the importance of femoral pulsations in the newborn? Should we go or there is no necessity?
The femoral pulsations are important for coarctation of aorta.
Okay. And suppose on day one, you were present, I will say attending person. You have examined honestly. You have mentioned femoral pulsations present. Fourth day, I was taking the postnatal round. And another resident was taking the round. He said, sir, that femoral pulsations are weak. How it happened? And it happened that at the time of birth, somebody had examined. He could palpate, even feel the pulsations. And second person is also right. That now the femoral pulsations are diminished or absent. I will say both are right. Then what happened? Who will give the explanation?
Closure of PDA.
Sorry?
Closure of PDA. If the coarctation of aorta, like the lower extremities, circulation was maintained by the patent ductus arteriosus, but after it closed, then the circulation was compromised. So it could be one case.
Okay. Many a times, you know, the PDA may misguide you. And therefore, very important what they say, that examine at the time of birth, see even the before discharge. On the follow-up also, again palpate. Similarly, see for the cyanosis also, may not be at the time of birth. Later on, it may appear. As we see for the jaundice on second or third day, and you know, every examination we should know that what I'm supposed to check or examine, or what is likely that now it might have appeared, which was not there at the time of birth. So these are the certain points which we should, I think before we go further, a word from Dr. Gaurav, please.
Sir, just with this point, sir, I would like to add. So coarctation of aorta is something which is a progressive disorder. At birth, it is going to be absolutely normal. When you progress, or it is something which appears on day 4, day 5 of life. So there are certain conditions which are present at birth. So as sir was saying at the beginning of this talk, we need to be very sure when we need to talk about hours and when we need to talk about days. Because there are certain diseases, if we see a child on day 2 of life who presents in shock, number one, consider something like coarctation of aorta. If your femoral pulses are not felt and you put a pulse of the probe on the lower limb, you're not able to get the pulses. You're not going to able to get a good waveform. Whereas if it is there on the upper limb and if it was there equal on day 1 of life, you could still be dealing with coarctation of aorta. That is a very important diagnosis. Number two, I would like to bring in something like metabolic disorders. They generally tend to come on later in life. They're not there at birth. As soon as the baby starts taking feeds, metabolizes them, and if there is a defect in metabolism, that is when it is going to come. Similarly, something like congenital adrenal hyperplasia, child may suddenly present in shock in second week of life. So these are certain things which present, which are not at birth but present later in life. Similarly, if we move a little further, look at biliary atresia, the bile or the color of the stool would be normal in the first month, whereas that would manifest somewhere at 4 to 6 weeks of life later on. So these are generally progressive disorders which tend to manifest in particular time frame. So Point number one, basics are very, very important. So as sir said, I am also learning something today. It is a privilege for me to learn, go back to the basics to my college days. Time and basics are very important. They're the fundamental stones. We need to go to what are anatomies, what are physiologies, and then we would get to the pathophysiology.
Thank you
Now,
very
one
much.
more question, sir,
Yes,
before
sir,
we complete,
please.
sir.
Please.
As we're talking about delayed cord clamping, as rightly Dr. Shivangi said, we need to wait for a minute. So the whole concept is what I would take it, I would again go back to physiology. Now, what happens in utero is in utero, there is hardly any blood flowing through the lungs. There is very minimal pulmonary blood flow. It is a seat of high resistance, whereas the placenta is a seat of low resistance. That is where all the gas exchanges are happening, right? Now, what happens is as soon as the child comes out from in utero to out utero, ex utero, every child has to go through a transition. What happens is the lung fluid gets replaced with air. Now, with air, the oxygen and lung becomes a source of gas exchange. Once that happens, air in utero is less, oxygen content in utero is less. We are dealing at a PA2 of somewhere at 35 when we are in utero life. Whereas when we come out, the lung starts working, the fluid gets reabsorbed. We are looking at a PaO2 of somewhere 60, 65, 70 millimeters of mercury. Now, when that happens is your pulmonary blood flow improves, your pulmonary vascular pressures come down because oxygen is the biggest vasodilator of your pulmonary vessel, pulmonary artery. So once that happens, your pulmonary blood flow improves. Once your pulmonary blood flow improves, your circulation, which was going in from in utero, goes to the ex utero, where lung becomes a seat of gas exchange. So you always tend to wait to cut the cord till you're able to establish normal respiration, because that gives time for the normal transition physiology to happen, and you give the child the advantage of fetal hemoglobin, which is going to be a boon because it decreases the incidence of anemia, decreases all sorts of problem, and it is in fact fetus's blood, so fetus needs to get that extra amount of blood.
Fantastic. He gave the explanation for even the delayed cord clamping, that why we are practicing like this. Anything, Dr. Gaurav, or should we go further?
So we can go further.
Yeah,
Just
yeah.
one comment, sir. Just one
Yes,
comment.
yes, sir.
Just because I would keep it to the basics. Now, since you're dealing with respiratory distress and preterm, please, do you know the components of Silverman-Anderson's scoring system? Dr. Shivangi or the presenter or Dr. Sandeep?
Surbi, you must be knowing because you have mentioned the Silverman and Anderson scoring.
Yes,
What are the components for the score?
the components are nasal flaring, grunt,
Very good.
upper chest retractions, lower chest retractions, and Gifford retractions.
How do you look at upper chest? What is the demarcation?
So, mild, then there may be some lag between the upper and lower, and then there will be seesaw respirations.
So essentially, when we mean upper chest, we are looking sideways. The baby's lying horizontal on the table. Upper chest is not the upper half above the nipple or below the nipple. It is more of looking a lateral view, looking at upper half of the chest and the lower half of the chest. So that is a very, very important thing when we are interpreting or deciding upon Silverman-Anderson scoring. So normally, once we breathe, the chest goes and chest and abdomen are in synchrony. When we breathe in, we let the chest wall inflate by negative pressure, which helps in bringing the air from outside environment to the inside environment. So normally they are in synchrony. If there is a lag in inspiration, normally the abdominal lags behind the chest in inspiration. That is grade 1 of Silverman-Anderson scoring for upper chest lag. And if there is seesaw, that means if the lung is expanding, the abdomen is going in the opposite direction. If the chest is going down, the abdomen is going up. So there's an non-synchrony. That is an important point for Silverman-Anderson.
Yes, yes. Thank you very much. I think one more point which we should remember nowadays, many neonatologists are suggesting that if you are present at a time of delivery, I think most of the times now we are present, and always note the umbilical vessels, numbers of your umbilical vessels. They said even put on your paper, make the routine column that how many umbilical arteries you have rotated. And therefore, single umbilical artery and its problems and associated conditions, very easily even you can. And they say that if you are present, this is very easy point to note it. And they say that put the point in your even the note so that it will be useful even in the future also. So all these points, I think gradually as we are learning, we should translate in our daily practice. So gradually it happens so that we are able to improve ourselves. I think with this point, let us go to again Dr. Surbi. You can take it further because we will have to look at the time also.
Clinical diagnosis is a male neonate, 4 days old, born out of a normal vaginal delivery, weighing 1300 grams preterm, small for gestational age, right soon after birth, is a case of respiratory distress syndrome in a preterm 34 to 36.
Okay. So I think this, but you have not gone for any investigations or anything. Anyway, no problem. You can stop sharing. No problem. No problem. I think we have the expert and we'll try to learn from it. Can you stop sharing? Suppose here even we don't have, but somebody will ask like Dr. Gaurav, and if you go for the chest X-ray, what you are expecting? Nowadays, even that is another way of exam, which some of the teachers may even practice in the exam. That before even examination, what you are expecting. Suppose from the history, somebody will ask that if you go for the examination, what points you are expecting? And I think according to our history, that means according to our clinical diagnosis, what are the likely positive findings? And suppose if it is not there, people say then go back to the history, something we have missed. Or even utter to your surprise, it is that means that is some unusual condition. And I think that is also the good way of our, I will say, clinical application. Similarly here, I think suppose like Dr. Gaurav, if you ask that what type of X-ray picture are expecting in this patient, which are clinical possibility. I think let us go to somebody else and then Dr. Gaurav will help us. Shivangi or Sandeep? Come on, Sandeep. Because you have participated from the beginning. Asmita, are you there? Okay, Shivangi is there. Shivangi, suppose sir is asking that as per this your history, your examination findings, your clinical possibilities. Now, if you go for the suppose simple investigation chest X-ray, what you are expecting that what you will get in?
So if we are expecting highly membrane disease, then there could be ground glass opacities, whole lung whiteout, or reticular opacities in case of, and less lung expansion as compared to the normal lung expansion that is supposed to be there.
Okay, I think in this way, this is very common X-ray, even in the exam also. So whatever the time we have, I think Surbi stop the presentation, but we have the many things. And I'm sure that we'll take it further, try to learn that this will be the very common X-ray in the exam. Let us try to know from Dr. Gaurav that what will be the peculiarity of the X-ray picture in a case of hyaline membrane disease. Dr. Gaurav, can you take us?
Yes, sir. So the very typical presentation, as Dr. Shivangi has clearly said. Now, we would just go a step further. Now, this is further classified as stage 1, stage 2, stage 3, stage 4 on X-ray. Now, if we see just an air bronchogram, that is typically called as stage 1. Stage 2 is the reticulogranular or the sand grain appearance. The only thing which is specific about hyaline membrane or respiratory distress is it's a uniform disease. You're going to see it on both sides, right? Now, if we go further, stage 3 is going to be a whiteout lung, but the cardiac borders are going to be made out. Whereas on stage 4, the cardiac borders would be obliterated. You would not be able to differentiate between the heart borders and the lung borders. So Air bronchogram, reticulogranular pattern, yes, lung hypoplasia would, or less expansion of lung would be there. Then it would be a whiteout lung with cardiac borders made out, and stage 4 is going to be your cardiac borders are obliterated. That's going to be a complete whiteout lung.
Then Shivangi, somebody is going to ask you that can you explain this radiological picture? Suppose air bronchogram. I hope you know the air bronchogram. And why it is appearing as an air bronchogram. Suppose if it is not there, what will be your differential diagnosis? I think first you try to answer why the air bronchogram is seen, or what is the air bronchogram, and why it is seen, or in a case of the hyaline membrane disease. And if not seen, what other possibilities are there? I hope my question is clear. Yeah.
So air bronchograms are particularly seen because the alveoli are collapsed in hyaline membrane disease. So the air in the bronchioles are clearly and more visible as there is no air in the alveoli. So we see specific and increased air bronchograms.
Is there any other condition, even in older children, where with the opacity air bronchogram is the characteristic? Radiological differential diagnosis. Commonly we see the condition, older children. I think she made the very good point that when the air bronchogram will be seen radiologically, try to understand. You know, normally in the lungs and airways, there will be air. And therefore, they are looking at the black in the plain X-ray. Am I right? Now, what happens in a case of hyaline membrane disease? What Dr. Shivangi said, that the alveoli are collapsed. They don't contain the air. And therefore, they are looking at the white opacity. But the air passages, they are patent. They are not affected in this disease. And therefore, air is there. And therefore, air is seen in the air passage, we say air bronchogram. That means any pathology where the alveoli are opacified due to any reason and airway remains the patent, you will get this type of radiological picture. One example, I remember in the older children, pneumonia. Pneumonia is the example where the opacity is seen with the air bronchogram. If this opacity is without air bronchogram, common differential diagnosis is pleural effusion. Because in a pleural effusion, we not get the air bronchogram. Because that opacity is in pleura, but it overlaps this whole lungs and the air bronchogram. So that's the point. Similarly, I think in the hyaline membrane disease, what Dr. Gaurav also mentioned and Shivangi said, that there will be some granular pattern. What does it indicate? The granular pattern is due to what? What structure makes it granular pattern? Shivangi, these questions are going to be there when you have scored good in the exam. You know, because he wants to assess you that, okay, fine. And further, many times, you know, the student has the good, I will say, performance. Gradually, examiner will change the sets of the questions. And for the good scorer, when the time comes for 2 or 3 questions, say, I don't know, then examiner will say, okay, fine, now you can go. So I think we have to reach this level. So somebody is asking that why these are a granular pattern in X-ray picture. In a case of hyaline membranes, with some stage as Dr. Gaurav explained us. That means what type of the anatomical structure gives this opacity, which is granular in pattern. Any idea, Dr. Surbi? I think Surbi was talking that she's the first year resident, is it, Dr. Surbi? Then I will appreciate that the first year resident, you were standing with this information and presenting the case. I would say just even the presence and standing is more than sufficient. I will appreciate. And anyone still, you put, I will say, good information. Anyway, I think suppose another patient with respiratory distress survey. But on examination, I found that air entry diminished on the left side and abdomen is scaffold. Shivangi, what will be your possibility?
Sir, congenital diaphragmatic hernia.
Why? Then what you are expecting at the time of resuscitation? Any problem? Suppose this may be required the resuscitation. The good, I will say, attending person should be able to catch the point. Suppose the baby requires some resuscitation. At what step you will find the difficulty?
So we should not give positive pressure ventilation by bag and mask because it could worsen the distress, or air could go into the intestines, and that could cause more
Yeah, that means in short, we do not, when we attend the baby, we are not sure that which baby has the which problem, right? But the point is, if you are knowing in your presence of mind, and if you note it, that when gradually you require the resuscitation step by step, the position and everything and cleaning, and then we were still not managing even with the stimulus, you go for even further step. And when you go for the bag and mask, you are expecting that with the one puff, second puff, the baby should become gradually pink. But here, rather than becoming pink, baby is deteriorating or becoming more cyanose. I think very first step, stop this resuscitation. Otherwise, what will happen, that we lose the baby. So I think as a clinician, first we should know. Second point, keep in mind when you are doing this, and then interpret and manage. And I think that's the thing, that how our learning process is that. That's why I will say, as students are there, just I'm talking, that this is very important, that, and if you continue, gradually, naturally become the master clinician. But that it's a continuous process. Anyway, I think what else you are expecting, Shivangi? Because Surabhi has made the diagnosis of hyaline membrane disease. What else you are expecting? Or I will say another thing before that, let us learn from the expert. Dr. Gaurav, can you tell us something for the surfactant therapy? That indications and even the preparations and even the methods of delivering, because I think it is very common. We have some time, so I think we want to utilize it with the, I would say, your expert things. Dr. Gaurav, you are muted. Unmute yourself, please.
So essentially, surfactant treatment has been a revolution in treatment of respiratory distress syndrome, especially in preterm babies. If you remember, there was a classical article, and John F. Kennedy's son died because of respiratory distress syndrome. That was in 1960s. Unfortunately, there was no surfactant then. So this was first put up by Fukuzawa in 1980s, but it was only after 10 years when the surfactant was actually FDA got FDA approval and was commercially available for use. And it was only late 90s when it first came in India. So there are two basic type of preparations. They are the animal derived and the synthetic derived. We are still using animal derived. They can be procaine based or pig, and the other one are bovine based. So Curacif, Cerventa, and Neosurf are three preparations which are currently available in India. So the whole idea is to give surfactant till endogenous production of surfactant starts, because once the child is born preterm, the stress hormones are going to shoot the production of endogenous production of surfactant. So till endogenous production doesn't start, this is something which helps inflate the lung, because your distending pressure is going to be 2T by R, 2 into surface tension divided by R, that is typical the Laplace formula. So by giving surfactant, since there is an air fluid level, you're decreasing surface tension and you're helping keep the lung open. So if your oxygen requirement, some say 40% on non-invasive ventilation, some say 30% on invasive ventilation, give surfactant. Early aggressive surfactant management is treatment of choice. First dose is generally at 200 milligram per kilo, and the second one is half the dose at 100 milligram per kilo. Some even recommend some units giving a third dose of surfactant. Now, as far as administration of surfactant is concerned, we are all become non-invasive. So the idea is let the baby breathe and let us give least amount of support. So we prefer going on non-invasive ventilation. So we give surfactant and we come out. So there is one which is Ensure, then there is Lysa, and then there's mist technique. So in Ensure, we intubate, give surfactant, and then extubate to non-invasive, that is CPAP respiratory support. So it's very once we are sure we are in, we check air entry, give off a shot of surfactant, make sure it is equally distributed, and then pull the tube out and let the child breathe. Whereas Lisa is we don't even put an endotracheal tube. We just go, there's a specific cath. We just put the cath beyond the vocal cords and administer the surfactant and put the cath out. So a LISA can be done while we are doing non-invasive ventilation, that is CPAP support. The CPAP is going on. We just put the tube, uh, visualize the cords, put a cath in while the non-invasive ventilation is going on, administer the surfactant and come out. So these are two major techniques of non-invasive administration of surfactant. Yes, if we find that we are not in a settings where our unit is mature enough to do LISA, where most units can do Ensure, then we do invasive ventilation surfactant, and then we continue on invasive ventilation. But as such, as a rule in neonatology, we have moved away from invasive ventilation. We are giving the work of breathing to the baby because we don't want, we're just going to be supportive of baby's ventilation. So less is better in newer concepts of ventilation support in neonatology. Non-invasive modes of ventilation and non-invasive support is considered superior to invasive ventilation. If we have to ventilate, but if we don't, as long as we can get away with it, it's good for the baby.
Thank you, Anut. I think very important daily what we are practicing. If we do with this understanding, it makes a difference. I think should be at least in an examination, you have missed one more point on eye examination. What routine you will get in eye? And when probably you may be afraid there is some problem with the baby, an eye examination. You know that I think for the newborn, certain points we should just routinely, certain points to be examined, not to be missed. And one of them, I will say eye examination. Routinely, even not necessary in this baby. Routinely, what you will get it. Suppose if you throw the light, how it will be appearing? Anybody else? Yes? Asmita? I hope she's there. Yes, Asmita? If you examine the eye in the normal newborn, what type of the reflex we say?
Sir, immediately the neonate will close the eyes.
Okay, that's right. we'll take care that we are moving and you will take the opportunity to examine. But suppose if you are able to see, what will the appearance? What type of the reflex people say? That is routine, I will say normal. And that is from the color, appearance of color. And suppose some other color, we take it with some serious problem.
So blue sclera, maybe.
Okay, blue sclera is different. I'm talking of the reflex point of view. Yes, somebody has put Dr. Amit, red eye reflex. I think Dr. Amit is here.
Yes.
What is
He's
this
one of our fellows.
Yeah, Dr. Amit, I think better you respond rather than write down on the chat box. We would like to listen to you.
Okay, sir. Normal presence of red reflexes normal in every newborn.
Yeah.
We have to look out for
and I think
white
it should be routine or part of our examination, not to miss it. Okay, Amit, take it further.
Yeah. So, sir, the thing that we have to look out for is white reflex.
Yeah.
whether it is unilateral or bilateral, because
Okay.
it is seen in number of conditions like congenital glaucoma, congenital cataract, and in also some IMs, metabolic disorders as well. So that is why it is very important to look out for this reflection.
Which metabolic disorder? Because you mentioned
Uh, metabolic disorders, it can be in congenital rubella, congenital
I think rubella is infection, not the metabolic.
oh, sorry. That can be seen in uh, uh, glycogen disorders.
Which glycogen?
Yeah.
Come on, I know that you have some ideas, may not be able to recollect immediately, but as a teacher, gradually I'm learning that give the maximum time to the
Glycogen
students to
storage.
recover.
I think that it was in glycogen storage disorders.
Or some other disease. Or this. I will give the example. Let us, I will say, from the illustrations, you'll be able to understand it.
Okay.
In one baby, I examine with some even the intrauterine growth restriction and hepatomegaly, splenomegaly, or even PDA, very specific CHD, and I got the cataract on examination. Then I'm sure that it becomes easy for you to say, Amit, what is the problem? IUGR baby with the cataract and even the PDA, I say.
IUGR plus cataract plus PDA.
Already
So
you
it's
mentioned.
congenital rubella.
Already you mentioned rubella.
Yeah.
Okay. But in another baby,
okay.
Suppose somebody examined as a routine that the eyes were normal, not the cataract.
Okay.
And somehow that baby had persistent or prolonged jaundice, hepatomegaly, and even this later on presented on examination, you got the cataract. Previous note is there, and honestly mentioned that.
In galactosemias as well.
Yeah,
and,
so now the answer has come. It's not the glycogen storage disease, but the
galactosemia.
And you know, that means after start, I think already Dr. Gaurav was giving one illustration that certain diseases may not be present, manifested at the time of birth. They manifest later on. Particularly from the metabolic point of view, he was talking, inborn error of metabolism. And you know here what happens that after starting the feeding, milk contains the galactitol substance, galactosemia, and that galactitol will be deposited at different places. On the eye, you will get the cataract. That is the acquired cataract. So acquired cataract, that means something else. Similarly, many metabolic disorders that once you start this milk and protein and everything, then amino acid disorders and something will be there. So the point is most of the metabolic disorders at the time of birth, probably baby may be normal. Later on, as even the feeding started or some baby is consuming, with this specific metabolic substance is not, I will say, utilized properly, then with the manifestation. So I think these are the few points, viewpoint point of view, which we wanted to bring to your notice. I think we have come to the end of time. We'll have to end over here, but I'm sure that Surbhi, even being the first year resident, her presentation was really very good, fantastic. And I'm sure that credit goes to Dr. Dara as a mentor.
Sir, good evening, sir. Sir, I want to share a few things.
Yes.
Sir, on behalf of our department, I'm telling you a few points. This is for the first time we have started case presentation with the first year residents.
Oh, that's
so
very good.
She was little bit apprehensive. I told Baldev Prajapati sir is excellent teacher. You will enjoy the session. Even at this point of time as a faculty, I still have so much experience of it was superb experience to hear you, sir.
Thank you.
Actually, you have given, and I have specifically told all our exam going third years to join this meeting.
Yeah, I think all of us are learning.
Yeah, this Shivangi, Sandeep, Ashmita, they all are our third year residents.
Yeah.
And I have told then and then you will get your exam related questions. So you have given a n number of questions which we routinely ask in PG exam.
Yes, yes, yes.
And
yes.
it was an excellent experience because nowadays we focus more on the basics.
Yeah.
Everybody knows about the ventilation, this surfactant, everything.
Yes,
But
yes.
we all should focus on the basics. That is also, I personally believe, sir.
Absolutely.
So that was an excellent experience, sir. And thank you,
Absolutely.
Dr. Gaurav,
Absolutely.
also
Yeah.
for the
Thank you.
neonatal points also. Sir, it was
Thank you,
really
sir.
a nice experience.
Yeah. I think definitely we'll have to go with the advancements. That is no
Yeah.
doubt they are required. But if you start from the basics, certain things will be
Definitely.
more clear. And many
Yes.
a times I will say management, interpretation, if you go only with the technology,
Yeah.
then probably somehow we are missing, and probably that may be the mismanagement or some problem or complication.
And like
And if you
they
go with
order.
the
What we observed in our routine practice, they order the
Yeah.
investigation so frequently and within a
Yeah.
minutes and seconds. But when they get the X-ray, what you teach, that is the findings they should find.
Yeah.
Otherwise, there is no meaning at all. So that is the basics. And if you don't know the basics, then the management will be difficult also. Even with the X-ray on hand, within 5 minutes also.
Absolutely.
So that's really a true, sir.
So I think congratulations, and even I will say I will convey one point to the students.
Yes, sir.
Never hesitate, even in the presentation and discussion and participation.
Yes, sir. That's true.
I will say what inhibition to us that I may not be able to answer. My answer may be some silly or may not be appropriate. I think we should not, even I'm sure that even being the Dr. Gaurav, the expert to me, many times we are not able to understand. Science is not so simple. So it's very certain. And on the contrary, to be very frank, if somebody is asking me, I'm not sure how much I am able to teach, but I am always learning. And that's why there are so many things Dr. Gaurav mentioned. Even I noted that certainly very useful in this advanced, and I know that exclusively he's working in that field. Certainly he'd be better knowing the subject than what even as a general pediatrician I am doing. And we are learning from each other. It's I will say mutual learning. So I would say, so students, we should never hesitate. On the contrary, participate. If you start to participate, you will learn more and more. And I'm sure the students will take this perspective.
Actually, sir, just before this session, I have told them, please actively participate, because there are so many like apprehensive, may not be knowing also whether they are allowed to participate or not. So I told specifically you are welcome to actively participate. Even who is not presenting.
On
so
the
they were
contrary,
little bit
on the contrary, Dr. Dara, many a time I have to take care that experts should not feel that he's not involved much, because I will give the first priority to the students.
Yes, definitely. And that is for students.
And that's why even I have to many times convey my limitation to the expert, that their expertization, probably we may not be utilizing much because we go more of the, I will say, basics. But I'm sure that if we go for the combination of our basics of clarity and even the learning from the experts, I'm sure that will be the better and better learning process. I think with that concept we are doing. So certainly I will have to mention over here, Dr. Gaurav, his presence made the difference in our discussion and learning. Not only I will say students, all of us learn a lot. Thank you very much, Dr. Gaurav.
We learn a lot.
Thank you, sir. Thank you very much. It was a pleasure learning from you, sir. It is an absolute gurukul. Thank you,
Dr.
everybody.
Gaurav, I have one question. You mentioned about the Lisa technique that actually we are not commonly using. So which catheter is you are routinely using for that technique?
Ma'am, I'm not using first and foremost. The main idea is it should not be very pliable. Means it should not be very soft, and it should not coil on its own. Some people are using cardiac catheters, 8 French to 10 French. The idea is it should not be too pliable, and it should be of a certain. It should not be too small in diameter, so that because surfactant is going to be thick. So it should be of decent size and not very soft, so that we are able to make it pass through the cord, deliver the surfactant, and come out.
Okay. So thanks a lot.
Even some people are able to deliver it through orogastric tube, 10 size,
Yeah,
aid
some
size,
people are
because
doing the with the orogastric tube. Yeah.
But let us try, because we routinely use in-show technique. So let us try
ma'am,
with
it
this
still works the
catheter.
best. Yeah.
Okay, so we can use orogastric also.
Yeah.
Okay.
Even
Thank
I
you.
will, I
That
will
But
take
whatever we do, we should be very sure about what we are doing, what we are using, and what could be
Yes.
the potential side effects. That's the only thing.
Sure. Okay.
Anyway, thank you, everybody.
Thank
I think I should take the note of presence of Dr. Charul also. She's also, I will say,
Yes.
good
Good
faculty
evening,
from Vijay Medical
Yeah.
College. Good evening, Dr. Charul. And even all other students, Shivangi, even Sandeep, Asmita, so many students. And I request them that please participate. Even after passing your examination, please continue so that you can learn the medicine. Thank you very much to all of you. And we'll have to end over
Thank you,
here.
sir.
Over
Thank
to,
you,
I
sir.
think,
Thank you,
Dr. Thank you very much. Dr. Nehal is there? Dr. Nehal, are you there?
sir.
Okay.
Thanks a lot, sir.
So on behalf of her, I will say her, thank you, everybody. Dr.
Thank you, sir.
Gaurav,
Thanks for
presenter, mentor, and all the
Thank you, sir.
teachers and the students.
Thank you, sir.
Next, I will say Saturday again, we'll be there with some new case. And good night to everybody. Good night.
Okay. Good night.
Good night, sir. Good night.
Good night.